The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Dr. David Beversdorf is currently involved in research on autism, dementia, cognitive effects of stress, the cognitive neuroscience of problem-solving ability, functional neuroimaging, and pharmacological modulation of cognition. His work has been published in journals such as Neurology, the Journal of Neurology, Neurosurgery, and Psychiatry, Proceedings of the National Academy of Sciences, the U.S., and Lancet. These webinars are made possible through generous donor support, including a grant from Local 25 Teamsters of Boston, Massachusetts. If you'd like to contribute, please visit our website at autism.com.
Today I'm going to talk a little about the interrelationship between gastrointestinal symptoms and stress markers and autism. Of course, everybody knows that there's a lot of comorbid conditions in autism, ranging from language impairment, anxiety, seizures, sleep disturbances, and immune factors and gastrointestinal disturbances, of course. But I'm always interested in the interactions between these. Hyperserotonemia is going to pop into this discussion as well, but I'm interested in the interactions between these, and certain ones that seem like they might be related to me. I wondered if perhaps they were. The autonomic nervous system is involved in the fight-or-flight system, and so sympathetic reactivity, if you see a tiger, oh my gosh, you get revved up, and the sympathetic system gets activated. The parasympathetic is the balancing rest and digest system, if you will. And this is involved at some levels in autism spectrum disorders. There's some evidence of increased resting electrodermal activity, suggesting increased sympathetic tone. There's evidence of reactivity to auditory stimuli, visual stimuli, facial stimuli, but there's a lot of noise in the data as well, suggesting there is heterogeneity in the population. There's also low cardiac vagal tone at rest in autism relative controls as well. But again, these data are a little messy. There's a little bit of variability in the autism population, which I find interesting because maybe that suggests subtypes. Immune functions are also an issue in autism. There is elevated IL-6 that's been reported, and TNF-alpha as well. And these are also associated with gastrointestinal symptomatology. And of interest, those are stress-reactive cytokines as well. So those seem particularly of interest. And there's also enhanced cortisol, which is a stress hormone response in autism, and there's a subgroup of responders and non-responders. So we were very interested in how all of these factors might interrelate to the gastrointestinal function as a whole. Gastrointestinal symptoms, the prevalence varies from 9 to 91%, depending on which paper you read. But a standardized assessment is needed, and it is associated with behavioral disturbances. It's 43% with esophagitis, and 13% have normal histology with sudden irritability and aggression as a comorbidity with gastrointestinal disturbances. And I remember Margaret Bowman and Tim Bowie talking about this being a big issue. Sometimes patients that they were nonverbal and they could not express themselves, had horrible behaviors, were found to have erosive esophagitis. It was causing them extreme pain. And they were doing a maneuver that the gastroenterologist, Dr. Bowie, recognized as actually a protective mechanism against that symptom, and they looked into it and found a significant number had a fair number of those people had erosive esophagitis, and actually that's not the dominant thing in this population. Constipation is very common in this population, and this is also associated with anxiety and sensory over-responsivity. Dr. Masrick, a colleague that was recently left our institution, was a wonderful colleague, and hope to keep working with her. Had looked into this question on a population basis and found that there was a significant interaction. So we were interested in looking into this further. And of course, there's the discussion of the gut-brain axis that everybody talks about, because there is a bidirectional communication between the gut and the brain. So is heightened stress response involved in gastrointestinal dysfunction, and how does this relate to immunity? This is largely the work led by my former graduate student and now postdoc, Brad Ferguson. He led there are two projects that came out of that we led, and Sarah Marler and Jeremy Veenstra Vanderbilt at Vanderbilt, and Jeremy is now at Columbia University, and also we worked with Kara Gross Margolis, who's at Columbia University, in this project, and we both worked through this together. We were part of the Autism Treatment Network and obtained funding through the AIRP mechanism to look at this, to really get a good idea on these comorbid conditions and how they interrelated. We did a GI screening to see what levels of gastrointestinal symptomatology we had, those with and those without. Ended up with a total of 120 children between the two sites. It was a big recruitment effort, and is accomplished wonderfully with the clinical research core here at the Thompson Center, as well as at the Vanderbilt Kennedy Center. What we did was, after consent, we did a pre-stress cortisol sample and a baseline EKG and skin conductance. And we then got a blood sample so that we could look at the cytokines. And we gave them a bit of a break, and then we did a stress reactivity protocol that consisted of vibrotactile stimulation, so a tactile stimulation for sensory hypersensitivity, and a cold pressor stimulation, which is a very, very traditional stress inducer. And then we did a post-stress cortisol sample as well, and we gave them the questionnaires to give you an idea of what the evaluation looked like. The assessment we did was we looked at the Vineland, we looked for aberrant behaviors, we looked at anxiety, we did a food frequency questionnaire, we looked at repetitive behaviors, we looked at sensory hypersensitivity, a global impression of GI sensitivity, of course, a medical history medication list. So we're really trying to cover the gamut of things that might be affected and related with this. And we also took the ROME-3, which assesses a wide range of gastrointestinal symptoms in individuals. It wasn't initially designed for autism, but Pat Levitt, I believe, was the person who started using this very cleverly, actually, for autism, because it covers so many issues and is relatively comprehensive. And it started to become used fairly widely in autism. We were early to that bandwagon, but we did something a little bit different. We generated a scoring rubric so that we could generate a numerical score based upon those survey questions and the scores generated by it, including a set of scores resulting from upper GI symptoms and a set of scores indicating the severity of lower GI symptoms to create a continuous measure that we could use in the analysis. Higher scores is greater severity of duration. And our sample was 90% male. It was a very homogeneous population, which is something that needs to be looked at in the future. Average age, they were youngish. The average IQ was 84, but you can see the range is 36 to 130. So it was a reasonably good spectrum of individuals on the autism spectrum. Functional constipation was very common, 42.5%. IBS was also reasonably well represented. Lower abdominal pain, a smaller percentage, and only a small percentage did not have any issues at all. So the stress response, 5-minute baseline, a siren, the vibrotactile stimulation, the cold pressor stimulation, then a washout. The vibrotactile stimulation was just a simple vibratory device. It had been actually used in previous studies to induce responses as well, and the cold pressor is very well established. As you can see, we did something that was actually suggested to us. It was very, very clever by colleagues at the University of Colorado and also at Vanderbilt. We implanted a rubber ducky at the bottom and asked them to hold the rubber ducky to make it more feel like there's a purpose to sticking your head in this somewhat uncomfortable cold water. You're hanging onto the ducky. That worked actually rather well. We measured skin conductance, which measures the sweat level, which is related to sympathetic response, and the EKG, the RR interval is one of the measures we focused on. Excuse me. And also it gives statistics from that can give you sympathetic and parasympathetic information. The PNN 50 is what we use, which is the variability of those beats. How many of the consecutive beats differ by more than 50 milliseconds, and then the skin conductance is how much the skin conductance changes. And what we found was that the patients with the more lower GI tract symptoms had greater parasympathetic tone at rest, but a lower reactivity to the stimulation, suggesting perhaps that they were already, the sympathetic tone was already at maximum, so that may be just a ceiling effect, so that they're getting a less reactivity due to the maximum already being present at rest in these individuals. But upper and lower GI tract symptoms were associated with sleep disturbance, and lower GI tract symptoms were associated with irritability as well. Interestingly, regressive autism, those that had a history of regression, had a greater lower GI tract score, which is very interesting. And those with anxiety disorder, depression, regressive autism and seizures also had greater upper GI tract scores. And one thing that's very interesting is if someone had anxiety, the relationship is very different. The parasympathetic and sympathetic reactivity based by the PNN 50 was significantly related specifically for those that had a history of anxiety, which does raise some question as to whether there's a subset of these individuals which the relationship is present for anxiety that may have implications for treatment. This also was found for the regressives, and we don't know what that means, but since regression is really one of the scarier things that occurs in autism, or one of the less understood things that occurs in autism spectrum disorders, there's something important there that really needs to be looked at further. We also looked at cytokines, the stress-reactive and GI-associated cytokines, and the stress-reactive hormone cortisol of these same individuals. The samples were obtained prior to and at the end of the study. Of particular relevance to get cortisol reactivity. We did an ELISA to evaluate these, and what we found was a positive relationship between cortisol reactivity and lower GI symptoms. So there's something else. So this is an agreement. Something very interesting is going on with the stress reactivity of these individuals. There's a modest relationship between one of the cytokines, the immune markers, the stress-reactive immune markers, and upper GI symptoms. But the increases in cortisol responses, which is an indicator of stress, did not translate into any effects on the stress-associated cytokines. So, at least in our sample, we were getting a stress reactivity, but not an immune stress reactivity. And once again, the regressive group had a very, very different relationship. Those that had a regressive change had a much stronger relationship between the endocrine marker and the cortisol change and the GI response. So there's something very interesting going on. Dr. Veenstra Vanderweel has long been very interested in there's a relationship with serotonin, and Sarah Marler led this aspect of it, and we all contributed to look at this in its relationship to the gastrointestinal symptom, which makes sense. 30% of individuals with autism have hyperserotonemia, and the blood serotonin is synthesized largely in the gut. And it was related to motility and inflammation as well. So that makes a lot of sense to look in this direction. And the thought is that maybe those with hyperserotonemia would have reduced GI motility, leading to that might be related to the functional constipation. And 23% of them did have 5-HT or serotonin levels that are above the mean for their race and pubertal status. And there was a relationship found when you look at the lower GI scores and the whole blood serotonin levels based upon the Z-scores. So this was supported. And there's also another study that was brought out of this, looking at confirming some previous suspicion that there is a relationship between gastrointestinal issues and rigid compulsive behavior. And this was borne out in our data fairly well when you looked at the whole data set, that there was a relationship between functional constipation and rigid compulsive behavior. So alterations in the brain-gut axis do seem to be characteristic of individuals with autism and lower GI tract symptoms. We have psychophysiological evidence of a relationship, and cortisol evidence suggests that stress reactivity is part of this picture. It's likely driven by constipation, as that was the main symptom that the lower GI tract, the people with the lower GI tract scores had. But it's not maybe a unified group, but there is a relationship between elevated serotonin and lower GI tract symptoms as well. And this also relates to many behavioral aspects. And so the interaction between the autonomic, immune, and endocrine responses seem to be important in constipation. Replication is needed. There are a number of issues at hand. How does this compare to non-autism populations? We focused specifically on the variations in gastrointestinal symptomatology within the autism population. And our sample with upper GI disorders, the original inspiration of this was the erosive esophagitis story and the stress reactivity there. We didn't have very many of those patients because the constipation is just way more common. And Jeremy gets a serious nod because he said we really need to look at constipation very closely, and I said that's a really good idea, and he was as right could be, and because we didn't really have that many of the uppers to track, and that's, I think, is still an important question, but will need to be targeted in future research. The GI symptoms were based on a questionnaire, and so it'd be really good to look at what's actually going on in the in the GI system. And Kara Gross-Margolis and I have discussed that in the past. And let's look at the enteric nervous system, which we did really, and the central nervous system interactions, which we didn't focus on as closely. And what are there other immune factors that could be related here? And obviously the microbiome is a good question here, because that's certainly going to be an important factor in any brain-gut interaction. And also larger studies could look at this effect if there's a gender-specific effect, or if there's, and also look at a more diverse population as well. In future directions, we are doing a couple things. As it happens, we're doing a very large clinical trial with propranolol, and our primary outcome was social and language outcomes and overall outcomes. This is funded by the Department of Defense, and the beta-adrenergic antagonists could conceivably have an effect on motility. There are beta-1, beta-2, and beta-3 smooth muscles in the human colon, and actually has been shown to be increased motility in a dose-dependent manner with propranolol before. So we will actually, Brad Ferguson actually, when we were doing this trial and these papers were coming out, said, hey, why don't we look at this clinical trial? And I was like, that's a great idea. Let's, because we certainly can. So because I was beginning to wonder, with the stress susceptible subpopulation, with the cortisol reactivity, the anxiety history, is there a subset of individuals with autism for whom there's a slightly different treatment approach that needs to be taken on, instead of giving a laxative like Miralax, or maybe in addition to that, maybe something to target the stress reactivity might be important for these individuals. And so we'll have to see if that plays out, but we are initiating that trial right now. So hopefully we'll have an answer with that in the coming years. It's going to be a few years because these trials take time to do, but it is underway right now. So we have a long way to go here with all these questions. The lab member leading the work in our lab was Brad Ferguson. Sarah Mahler led the work at Vanderbilt. Jeremy Beechner-Vanderweel at Columbia University was the lead for the latter two studies and the lead for the Vanderbilt site. He's now at Columbia University. Eric Backlund, Lily Altstein were critical of the statistical analysis. They handled that for us through the MGH stats collaboration with the AIRP program and the ATN. Evan Beatty-Lee was our collaborator at Vanderbilt with a whole range of the comorbidity issues. And Kara Gross-Margolis kept us honest on the gastrointestinal issues. We really needed her expertise to handle that aspect of it because we didn't have any, because we realized coming into this that we really needed a gastroenterologist, and Paula Margaret Bone was part of the initiation of the study as well. And our site also had some incredible help from Caitlin Hartnett, and Danielle Severance, and Brianna Killey, and the research core of Jill Akers, Nicole Takahashi, Robin Wilcox, and also Kristen Soul and Stephen Caddy were very involved in helping us move forward with this project as well here at the Thompson Center. So we have a ways to go, but this is a nice first step forward. Dr. Levitt is actually doing a big piece of this moving forward through his project as funded by Autism Speaks. And we're actually going to see if there's a treatment aspect of this that's relevant. But a lot of these factors are closely interrelated in autism spectrum disorder, these comorbid conditions. I think the better we get a handle on it and the better we understand the subtypes, the sooner we can move forward to begin to develop individualized treatment approaches. Thank you. And I guess it's a relatively brief story, so it leaves open a lot of time for questions.
I know that you can't give medical advice over the internet, so I'll try to avoid asking for any specific treatment recommendations. But maybe we can talk about some of these questions in sort of a high-level, general way. One of the themes I'm seeing, questions that I'm seeing, are about constipation and diarrhea, specifically about patients who switch off. So if you see constipation and diarrhea in a patient and you see these they're making similar behavioral observations to what you're finding in this study. So they link that to different trends in the way that their loved one is behaving. So what causes that? What causes the switching off of constipation and diarrhea, and what might parents or physicians be thinking about when they see that in a patient?
That we don't know. At the highest, you might, if it's really severe, you might actually check get a consultation with a gastroenterologist to see if there's something going on, like an obstruction or an impaction or something that really needs to be more aggressively treated. So I think that would be a reasonable thing if you're having a severe problem with that, to get a consultation with a gastroenterologist, which I am not. I'm a neurologist by training, but nonetheless, that's where I'd go with that. And we don't really have a good handle on it. That's kind of why we were trying to look into this, to see if stress reactivity may be something that's part of this that we need to approach differently. You could give laxatives for people that are more pure constipation, and you could give slowing agents, bowel slowing agents for people who have mostly diarrhea. And sometimes people are having severe, some people have encopresis because they have severe constipation and it finally breaks through. So it's a very complicated issue, and sometimes consultation is necessary.
Okay. People are asking more about serum hyperserotonin. I'm not sure that that's typed in there correctly, but talking about how that relates to the GI, and you touched on that quite a bit on the talk. But and I know Dr. Margolis, we've got a talk from her as well, but do you have insight about any current discussions that are happening around that relationship between serotonin and GI, or future research that's being planned?
Well, I will tell you that Kara Gross-Margolis is the expert on that exact topic. So, but I think it gets back to the issue of subtypes. There's something very meaningful about that subtype, the ones that elevated blood serotonin, and we don't yet have a good handle on why. It may have implications for medical treatment. I mean, maybe they're going to respond differently to drugs. We don't have a good handle on that. It probably has something important to do with the gastrointestinal system as well, but we don't have a good handle on that yet either. So that's why we need some larger studies to look at these questions in a comprehensive manner and begin to get a handle on that question. So I'm afraid I'm answering the question with more questions. But we have the right people looking at it, and Kara is that person. Frankly, she's great as far as this topic. She's the one I'd be asking.
Okay, great. And just for anyone who's listening, we've got a couple of talks actually by Dr. Gross-Margolis on our website at ariconference.com. So she did one fairly recently. So if you'd like to listen to that and learn more about that specific topic in depth, please visit the site and check that out. So Dr. Beversdorf, I'm sure you're anticipating I'll ask some questions along these lines. Quite a few parents have asked about nutrition. And I know that you're not a nutritionist or a gastroenterologist, so I know you can only frame this from the perspective of a neurologist. But I know that we also talk about the gut being sort of the second brain. That's been a wider and wider conversation. So what do you know about the nutritional aspects of this, and what might be valid pathways that people could be exploring?
Well, that's the weird thing. Actually, look at that. We took the food frequency questionnaire. Some of you may have caught that. And we are actually looking at that data now, and thus far it looks like, kind of shockingly, that there was not a relationship. One could predict a relationship in either direction. It could be that people are avoiding types of foods because they're getting constipated. It could be that an individual with autism has a really, really restricted diet and only eats French fries. That's causing their constipation. Maybe the constipation is making them only eat French fries. So one could predict all kinds of ways there's a relationship in either direction. And we did an analysis of the food frequency questionnaire, and none of them are associated with the gastrointestinal symptomatology, which is really quite surprising. Now, admittedly, that could be sometimes. There could be a group that shows a relationship, another group that shows the opposite relationship, and you end up with nothing in the end. But that there is, as a population, no obvious relationship between these symptoms and diet, which was quite a surprise that it would be that cleanly negative. But that's the whole population taken together. So we don't have a recommendation as far as diet, except for the common sense things of if you have of the dietary interventions that are typically recommended for constipation. You get lots of fiber, drink lots of fluids that you'd get from anywhere else. Nothing else was really brought out in that data, taking this whole sample.
Okay. So in terms of nutrition, did you subset it at all for for patients who are gluten-free or dairy-free or any of those specific diets, or was that something that wasn't segmented out?
We didn't segment it out because the numbers we had in that particular group were not big enough to really do a robust statistics on. That would take a much larger patient population to be able to sort that out. Got it.
Okay. Since you were selecting the patients based on other criteria, you weren't selecting them based on what kind of diets they were following.
Yeah, we were just as whether the dietary frequencies had any relationship to gastrointestinal symptomatologies.
Yeah,
we didn't have 120 is good for that question, but it's not good enough to break it into smaller subtypes. So
yeah. Okay. There's a question here. They're asking about constipation. And again, I know you're not a GI doc, but they're talking about the relationship between constipation and the symptoms that you described of the lower GI. So could you just really briefly re-summarize that exactly? Was constipation associated more with sleeplessness, or was it associated more with hypersensitivity, or what were the symptoms that you saw specific to that?
Well, the lower GI, the actual slide, so I can make sure I get every one of them right.
Yep.
Because the others are easy to summarize. So the lower GI was definitely related to sleep, and it was related to irritability specifically. At both upper and upper was also related to sleep and the psychophys reactivity. We also, and so, but then as far as anxiety, there was a relationship as well with the lower GI and loss and the regression. The anxiety was not specifically related, but it modified the relationship. So the upper GI symptoms, even though our numbers were small, it was related to everything: anxiety, depression, loss of skills, regression, and seizures. For the lower, it is a very discrete relationship with loss of skills, regression. But the thing that happened as well is the relationship with the psychophysiological autonomic reactivity and the lower GI score was strong only in those that had anxiety. So it suggests there's a subset. Anxiety represents a subset that's different in the as far as people with gastrointestinal symptoms. And then, of course, there was the cortisol reactivity as well, and the relationship with the irritability as well as right there, the rigid compulsive behavior.
Okay. And I know you talked just at the very beginning about seizures and some of those things. Was any of that sorted out during the study? Any tendencies for seizure activity?
Only in the increased upper GI symptoms was associated with seizures. But again, our upper GI population was relatively small, so we'd want to look at we'd want to see that in a population that's more targeted towards upper GI.
Okay, so you're saying to parse that out further, we'd need to really target that upper GI group.
Yeah.
Yeah, so we'd segment that and then look at seizure activity. Any idea why? Why would seizures be more common in upper GI? Any theories on that, or would you hesitate to speculate?
I don't know. I'm not as confident of it, so I don't want to speculate too much. But if there's a tendency to have seizures, one could certainly reasonably expect that the pain induced by the upper GI problems could lower the seizure threshold. Maybe the seizures themselves are affecting the gastrointestinal system and leaving it more susceptible. And of course, the brain-gut axis and microbiome may play a role as well. We don't have a great handle on that at this point. This is a relatively new area of exploration, so there's a lot of unanswered questions.
Right, for sure. Would any of that relate to cortisol reactivity potentially?
Yeah, that's certainly another indicator. It's a nice confirmatory piece to suggest that stress reactivity is important in all of this, and so cortisol reactivity would fit that picture.
Okay. And do you think the research that was done, you focused on children, would it be reasonable to extrapolate this out to adults?
Well, we actually did it out to, here, I'll look here, the patient population. It said here, there we go. It went all the way up to 18, so we were capturing the lower edge of that. My suspicion is that it would probably hold true in the adult population. The ATN, this was done through the ATN, so the population was up to 18. So it was kind of built in that way that it was going to be children in early youth, and so we weren't really targeting the older population. I would think it reasonable to think that it would hold true in older individuals, but my clinical experience, they still have the gastrointestinal issues when they're adults, but it doesn't stand up to be like the first issue that they complain of, or that the families complain of, because they've already kind of developed whatever coping mechanism they have for it, even though it's still an issue, it's still a problem. So it's less often the primary complaint, or a primary complaint, because, oh yeah, no, there is terrible constipation. If you ask about it, yeah, no, it has terrible constipation, but we've managed to figure it out with enough laxatives, or a super heavy fiber diet. So the incidence doesn't seem to change, but the coping mechanism seems to have evolved by the time adulthood is reached. But I would suspect otherwise that it would probably hold the same. I don't see a reason why it wouldn't.
Okay. Yeah, this is an interesting question. It's a parent asked this question, and they said, based on what you know, which came first, the GI problems or the autism?
Well, we know that the autism, that the majority of the cases have a genetic preponderance. So the genetic load is really high. So we know that there's a gene that's pre-programming this, or a group of genes pre-programming this in the majority of cases. And for those that aren't associated with specific genetics, there's maternal antibodies that are present. They're antibodies to fetal brain, and that there's beginning to be some evidence that maternal stress exposure in those that are susceptible may be a factor as well, but all of those would be most likely to target brain. So I think what we're going to find in the end is that the gastrointestinal system is not causative per se, but is an important cofactor in outcomes as far as behaviors, severity, and other issues, as particularly these other comorbid issues, and that optimization of treatment of that may be very helpful. So I think when it's all said and done down the pike, that's my suspicion about how it'll play out, that it won't turn out to be causative per se, but the interplay between the brain and the gut may be important for optimization of outcome.
Got it. Okay. This is a parent, so I'm wondering as a physician if you may have insight on this one about this person's just asking about obtaining referrals based on GI symptoms, or based on seizures, different symptoms that their children are having. Pediatricians sometimes they don't want to overreact, I think is her assertion, but she feels that she needs referrals for these GI symptoms, and because of the diagnosis of autism is having a difficult time. So do you have any insight or advice or keywords a parent might use to try to positively support the physician?
I think it depends on the individual case. There's a couple ways to go. If the patient themselves is minimally verbal and it's behavioral disturbances, and you're suspecting that is being contributed to by gastrointestinal problems, then there's ample evidence that could be a gastrointestinal issue. And the Tim Bowie paper at Pediatrics is a great place to go for that. But there are others as well. It's easy to find references for this to make that argument. The second one is if there's a severe obstruction or something that may be going on that may be a medical risk. And if you're worried about the constipation is just so severe, gee, I'm worried about whether we've got toxic megacolon or some other condition that is causing major impaction and maybe causing potential health problems, that could be a query as well. So those are a couple of indications that would lead one to referral with a little more definitiveness. It's a hard thing to do because sometimes it's very hard to overcome sort of a laissez-faire attitude. But there is growing and mounting evidence that if you're having GI issues, that it may be a reasonable thing to seek consultation. There's a second issue is that it does vary from place to place how interested a gastroenterologist might be in this topic. There are places where they have wonderful gastroenterologists that are involved in it. So maybe talking to a regional autism resource for some advice locally to find a good place for such a referral might be a good another strategy to carry out in this quest.
Excellent. Thank you. That's great advice. And I wanted to add to that, definitely printing out papers, not to offend the physician, but maybe just to inform them. We also have a lot of talks by very qualified experts on ariconference.com. If you've got a physician who you think might be open to watching it, we've also done some talks with the Cleveland Clinic with Tim Bowie on the GI issues, and those are free, and the physicians can earn continuing medical education for attending those online. So if you have a physician who you think might be open-minded enough and would want some free continuing education, that's a way to get that in front of them. We do have printable flyers on our website too that you take and print. So if anyone needs any help obtaining those, my email address is denise@autism.com, and people can get those. I can send the link. So there are many more questions here, and I know we could go on forever, but I'm going to ask you just a couple more. I've heard this over the years from other parents, and you may have seen this come up, and I don't know if it did or not, but they're asking about when a child or a person has a temperature. So if they have the flu or something and they have a temperature, and then they see an improvement in their attentiveness or their verbal behavior, and typically this happens the most with sort of a stomach flu. So I don't know if you observed anything like that in the study or if you've seen any information about that, but I just wanted to throw it out there if that's a topic that's come up.
Not in the study per se, but I do know a bit about that topic because Andy Zimmerman is now doing a clinical trial based upon the principles of this. I heard him discuss the proposal of that trial at a series of talks a few years ago. It's quite fascinating. Yes, it happens. It's a subset of people for whom it happens. There is clear improvement in some people. It's reasonably well documented. We have no clue why. Andy Zimmerman, though, looked into this and said, Karen O'Connor, Andy Zimmerman, Karen Connors, looked into this and tried to look at the mechanism of fever that might be relevant. And they found one agent that actually brings about some of the aspects of fever without actually being sick. And it's an extract from broccoli sprouts. And it's called sulforaphane, and there's now a clinical trial funded by the Department of Defense looking at this agent for autism. And they had a paper of their pilot sample in the Proceedings of the National Academy of Sciences that looked pretty favorable. So this, while we don't fully understand it, this has led to a prospective agent being studied in clinical trials. So it's an interesting question, and hopefully we'll get some sort of answer in a couple of years.
Okay, great. Thank you. I know that's a complicated question, but it does come up from time to time. So I wanted to make sure I got it out there. So for everybody who's still on the line, we have resumed our webinars for the year. So be sure to check out our website at ariconference.com and get signed up. We've got dozens already planned. And Dr. Beversdorf, I really appreciate your time today. We'd love to have you back this year to talk about some of these things further.
Sounds great.